Please join me in welcoming Dr. Chris Thurstone.
All of you in the clicker? Oh, underneath. Okay. Okay, my name is Chris Thurstone. I'm a child psychiatrist and addiction psychiatrist, associate professor at the University of Colorado. Thank you to the University of Colorado School of Public Health for organizing this and for inviting me to be here. I'm talking about marijuana and drug abuse today, and in terms of my disclosures, I'm employed by Denver Health and Hospital Authority, and I get some grant funding from the National Institute on Drug Abuse to do some research. In terms of what I'm talking about today, just going to cover three main things. What is cannabis use disorder? Who presents with it? Who's most vulnerable to getting it? And what is, trying to end on some good news, what's cannabis use disorder treatment and what can we do about it? So cannabis use disorder is diagnosed the way any substance use disorder is diagnosed using our DSM, Diagnostic and Statistical Manual of Mental Disorders. We have a new 5th edition now, but this is a research study here that was done comparing adults who present for marijuana use disorder and those presenting for cocaine use disorder, comparing all the different symptoms that they present with. And really, I think the main finding from this study was that they present with similar symptoms in terms of DSM. So, for example, if we march down this list here, just get this right. Continued use despite significant problems. That is 97% of people presenting for marijuana treatment reported that. Persistent desire to cut down, 86% of people reporting presenting for marijuana treatment reported that. Using larger amounts than intended, 80% reported that symptom. Spending excessive time obtaining, using, recovering from the substance, 73%. Marijuana withdrawal, which we'll talk a little bit about that more later, but having an abstinence syndrome if you don't use the substance, 75% reported that. Tolerance, meaning that they needed to use more to have the same effect, 63% reporting that. Using to relieve withdrawal, 65%. Frequent intoxication or hazardous use, like, for example, driving under the influence or smoking in bed, something like that, reported by 53%. Activities decreased, so giving up other activities, hobbies, interests, in order to use the substance, 41% reported that. And you see there are some differences here with comparing to people presenting for treatment of cocaine. In terms of people with cocaine, more likely to report using larger amounts than intended, more likely to report excessive time obtaining, using, recovering from the substance, more likely to report tolerance, and giving up other interests. So that's a little bit in terms of what marijuana use disorder is, or cannabis use disorder. It's thought to affect about 1.5% of adults in the United States, thought to account for 2 million disability-adjusted life years worldwide. All right, other clicker. Lifetime risk with use, so what percentage of people who try it once in their lifetime go on to develop a cannabis use disorder or a substance use disorder? The latest data that are out there in a peer-reviewed setting in the Lancet Medical Journal is that about 9% of people who try marijuana go on to develop a marijuana use disorder. Just for reference there, I put other substances there as well, and so you can see, compared to other substances, this is a lower number. Now, a couple things, too, as Dr. Riggs mentioned, the earlier somebody tries marijuana, the more likely they are to develop addiction to it. So the number that's currently published is that 1 in 6 adolescents who tries it before the age of 18 will develop a marijuana use disorder. And so that's a greater number if you start earlier. I will say also that these data, especially for marijuana, were done a long time ago. These studies are pretty old studies, and really we need new information, new data around this. Physical dependence, I think, is a kind of a relatively new thing in terms of cannabis, talking about cannabis use disorder. I hear it a lot with my patients in terms of, well, even if it is addictive, it's only psychologically addictive, not physically addictive. So this new physical dependence is a relatively new thing in the research literature here. And it is in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, that came out in the spring of 2013, now formally recognizes cannabis withdrawal as a diagnosis. But this is a slide here comparing people, adults with marijuana use disorder and tobacco use disorder, and comparing them on 9 different symptoms of abstinence. So, for example, feeling more irritable if you don't have your substance, having difficulty with insomnia, as some examples. And they rated each of their 9 symptoms on a scale of 0 to none, 3 severe. So here, 0 would be no marijuana withdrawal or no tobacco withdrawal. 27 would be maximum withdrawal symptoms. And so what they found was that among people, comparing people with marijuana use disorder, tobacco use disorder, the physical dependence was about equivalent. You can see 13.0 compared to 13.2. And physical dependence, physical withdrawal symptoms accounted for 50% of relapses to marijuana in adults who tried to quit using it. So it's thought to be clinically significant. And so that is an area of research as well in terms of, okay, if it's clinically significant, how to treat it. Oops, did I go back? Sorry. So more about cannabis use disorder, and we're getting into the who question here, who gets it. But this is a paper from the Journal of the American Medical Association, Dr. Compton et al., 2004. And what it showed was that the rates, the prevalence of marijuana use in the United States as a whole stayed about the same. About 4% of adults used marijuana in the last year. But what they found was that the prevalence, past year prevalence of cannabis use disorder, that's what CUD is, was increasing significantly during the time frame from 1991 to 2001. And it was increasing especially among young people, 18 to 24-year-olds, so they only studied adults in this study here. And it was increasing especially among African Americans and Hispanic Latinos. So let me just walk you through this graph right here. So this is the percent of the population with cannabis use disorder on that y-axis. This is year 1991 to 2001 here. You see Caucasians had a non-significant increase from 1.25% to 1.4%. Among Hispanic Latino youth here, these are just 18 to 24-year-olds, 1.25 to 2.9%. African American youth from 1.25 to 4.5% there. So rate of cannabis use disorder seems to be increasing. The overall conclusion of this paper or speculation was that this likely has to do with the increasing potency of marijuana, since the prevalence of use was staying the same, but the prevalence of cannabis use disorder was increasing. These are data that we presented at the American Academy of Child and Adolescent Psychiatry last year, 2013, and let me just walk you through it here. These are youth who present to substance treatment here in Denver at Denver Health, 560 of them, dating back to 2007 to 2013. And we have their urine drug screen THC to creatinine ratio here on this y-axis, and we have pre-2009, post-2009 here. Why 2009? That's when we had our big commercialization and medicalization of marijuana in the state. And actually our experience at that time was that we had showed in 2 peer-reviewed papers that up to 74% of teens in substance treatment were using medical marijuana that was being diverted to them. And we also published the finding that those using medical marijuana compared to those not using medical marijuana had more symptoms of cannabis use disorder. They seemed to have more severe addiction than the ones not using medical marijuana. And so, and our experience was that these youth who were using medical marijuana products were starting to use very high-grade medical marijuana products, very potent. So waxing marijuana, dabbing marijuana, using bubble gum, these products we had never heard of before. And so we were interested to see, well, is there a rising exposure to THC among these youth? And these are data showing that the average THC to creatinine ratio here indeed went from 361 to 479 pre-post 2009. We also showed that youth post 2009 were getting worse treatment outcomes, likely because they were presenting with more severe cannabis use disorder in the first place. Also, there's an interesting point out there. Some people argue that these highly potent products are a good thing because then youth will use less. Instead of having 4 hits of marijuana, they'll just have 1 hit, for example. And what these data at least show, these are more consistent with the idea that youth are they're actually being exposed to more marijuana. They're not self-titrating downward and using less of the product. So in terms of who's presenting with cannabis use disorder, marijuana accounts for 16% of all substance treatment admissions, so adults and adolescents in the United States. It's typically the second most common reason why people present for substance treatment behind alcohol. Among youth, however, it accounts for 66% of substance treatment admissions. So this is the table here is looking at adults presenting for marijuana treatment. 63% of them are male. You see the age differential there. And I think an interesting story here that Dr. Riggs covered very nicely too was that 94.4% of adults in substance treatment for marijuana report a co-occurring psychiatric disorder, axis 1 psychiatric disorder, such as major depressive disorder or something bipolar disorder. And a significant percentage also, about 89%, report another substance use disorder, and that's not including nicotine. So co-occurrence of psychiatric and substance use disorders really seeming to be the norm. These are data for adolescents presenting for cannabis use disorder from the Cannabis Youth Treatment Study, 79% of them being male, 83% being referred for treatment by the juvenile justice system. And I just want to underscore the point that Dr. Riggs made too in terms of when there's an idea that people have to be referred by the juvenile justice system to go to treatment for marijuana use disorder. In the research studies we've done in which we're able to offer free treatment, the percentage of teens presenting for treatment of their marijuana use disorder is significantly lower. And they'll come and they are retained in the treatment, really getting at the idea that very well might be an artifact of the third-party payer system, that in order for youth to get treatment now, they have to drop out of school, get involved with juvenile justice, and then they get help. And so there's an area of opportunity for growth right there in terms of really going into the schools and providing treatment before that happens. Alcohol use disorder, youth are also presenting with multiple symptoms, alcohol use disorder, other substance use disorders. And then in terms of psychiatric disorders, 80% of youth in treatment for cannabis use disorder have a co-occurring psychiatric disorder. So that really is the norm. And again, integrated mental health substance treatment is what these youth need. Treatment. Okay, so some good news, what to do about it here. Seems like the best treatment overall combines some things in terms of comprehensive assessment, individual motivational interviewing, which is really an empathic, non-judgmental way to motivate people for positive change, including also cognitive behavioral therapy, which is the most very well-studied psychotherapy that really helps people change the way they think, change the way they act, including incentives here. So basically, in our youth program at Denver Health, rewarding kids for clean urine drug screens, for getting involved in pro-social activities, for showing up to treatment, And there's very cost-effective and clinically effective ways to do that we could talk about later. Case management I put up there because really relapse rates following substance treatment are so high, 60% within about 6 months relapse. So really getting people involved in positive activities that keep them clean over time. These are prognostic indicators in terms of substance treatment and just co-occurring psychiatric disorders being a poor prognostic indicator. Marijuana use disorder severity at outset also being a poor prognostic indicator. And so just to summarize here, cannabis use disorder presents with multiple diagnostic statistical manual mental disorder symptoms. Disproportionately seems to affect males, youth, minority youth. And then the treatment there seems to be motivational interviewing, cognitive behavioral therapy. CM is contingency management, the prizes I talked about, integrated mental health substance treatment, and trying to get to youth especially before they're dropping out of school and getting involved in juvenile justice. So with that, I'll close. Thank you very much for your time.
Thank you. Questions? Yes.
So, Christian, great talk. I think one of the things I think is interesting is most of us,
Talk right into it.
most of us, when we went through our medical training, were taught that cannabis is not physiologically dependent at all. I was wondering if we know anything about the amount that someone has to use to develop physiological dependency, so that there's actually the withdrawal symptom.
Right. So the question in terms of amount that they have to use in order to develop the physical dependency, I think the short answer around that is it's not exactly known. So daily use is typically defined as using 20 out of the last 30 days, and that's frequently what youth and adults in substance treatment for marijuana present with. And we know that about 2/3 of youth in substance treatment for marijuana report 4 or more physical withdrawal symptoms to marijuana, and about half of adults in substance treatment for marijuana use disorder report 6 or more symptoms of marijuana withdrawal.
Other questions?
So I just had a quick question. I'm really glad you brought up the issue of the juvenile justice referrals. And so, with drug courts being responsible for over 50% of those going into treatment for marijuana, my question is from a researcher's point of view, how do we disentangle someone who's sitting in front of a clinician knowing that they have to present as someone who has a dependency problem or they may go to jail, and, kind of that bias of prohibition and really understanding who actually has a disorder? Because in the new DSM, they actually took out the qualifier of I use even though I get in trouble with the law, because they know that certain people are more likely to get in trouble with the law than others. So from a researcher's standpoint, how do we disentangle people that actually have cannabis use disorders and people that are saying so because they want to remain in treatment versus go to prison?
Excellent point. So basically youth, when they're assured of confidentiality, asked in a very non-judgmental way, tend to be very honest, brutally honest about their substance use, number one. Number two, in the research we've done, we haven't seen different outcomes in terms of court-referred youth, voluntary or non-court-referred youth. We get the same basic outcomes. Why? I think because we're doing motivational interviewing, we're doing an intervention to actually motivate people for positive change. Also including the motivational incentives, prizes for clean urine drug screens. So we're doing a couple interventions to actually motivate people for change, whether or not they're court referred. But it's a great question.